Hi everyone, welcome to this webinar. Before we get started, we actually have a couple poll questions that we'd like to ask you. So if you're logged into the GoToWebinar software, we're just launching a quick poll here if you want to go into that section and just answer which one best describes you. Great, it looks like everyone has voted. Moving on to the next question. Couple more seconds if you haven't answered this question. Another one here for you. Great, and one final question. Thanks for your participation here, and we'll get started. %88 of you have voted. Get your last selection in and we'll get started here. Okay, closing the polls now. And if you can hear me well, please just let me know in the chat function that you can hear okay, or if you're having any sort of technical issues with hearing us. Otherwise, I'm just gonna share my screen and we're gonna get started. Great. So welcome everyone. So if you're here specifically for the COVID-19 substance use pandemic prescribing related to the clinical guidance, and specifically this is a session for our Fraser Health Authority folks, you've landed in the right place. So I'm Amanda Giesler and I work at the BCCSU and I'll be your moderator for today. So before we get started, I know that many of the folks on the line are from Fraser Health, but for my colleagues on the line today, we just wanted to do an acknowledgement about the lands on which we work on. So just respectfully acknowledging the land on which we work is the traditional territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. But just also taking a moment in Fraser Health, depending on where you are, recognizing the lands in which you're listening in from today as well. So here's our agenda. And so you may have attended a webinar from us in the past, in the last few weeks, in which case you would have heard more of a didactic session about the safer supply guidance or the interim guidance. Maybe perhaps you've read them already, but today is really to give you just a mini background around the guidelines, kind of walk through what it means to be a clinician in Fraser Health in relation to these guidelines. But really we're hoping that we can spend a bulk of this time together today to discuss some cases. If you have questions, if you're unclear about something, you feel uncertain about the guidelines, we're really hoping that we can make this conversational. So during the presentation, let us know in the chat if you have questions and we can answer those. But we do hope that we can open up the mics and we can have a more open conversation and you can ask your questions directly to our amazing presenters today. But that brings me to our two amazingly talented women who are going to be presenting to us today. So we have Dr. Christy Sutherland and Dr. Sharon Vippler. And I'll start with Dr. Sutherland. So she's the physician education lead with us here at the BCCSU, a family doctor and a diplomat of the American Board of Addiction Medicine, and works in the downtown east side providing care to Canada's most vulnerable population. Dr. Sutherland is the medical director of the Portland Hotel Society, where she leads a team of physicians and nurses who are embedded in low barrier harm reduction projects. Also doing a plug that she was Canada's Family Physician of the Year, and we're very lucky to have her. We also have Dr. Sharon Vipler, for those in the Fraser Health region, no stranger to you, as she is the addiction lead for your health authority. She's the program medical director and regional department head of addiction medicine and substance use services at Fraser Health. She's a diplomat of the American Board of Addiction Medicine, and clinically she works at the Creekside Withdrawal Management Center, Quibble Creek Oak Clinic, and with the St. Paul's Addiction Medicine Consult team. So with that, before we get into the meat of the presentation, I also just wanted to pass it over to Dr. Vipler to give us some opening remarks about what this means for Fraser Health, the work that's been done to date, and maybe some context setting for your health authority. Over to you, Dr. Vipler.
Yeah, thanks. And thanks to everybody on the line for joining at the end of what I can only imagine has already been a busy and long day. So thank you for being on the call. The conversation about having a webinar specific to this region really started soon after the release of the guidelines. There was a lot of questions, there was a lot of concern, there was a lot of distress expressed about how do these guidelines fit within our region? When should we be using them? Are we quote unquote supposed to be using them? Are we in some cases, questions about have we been mandated to take this approach? So there was a lot of uncertainty, and that was uncertainty that is completely and totally valid and fair, given that in hindsight, when I look at all of the changes that were released that week, it was the same week that the federal government announced the changes to the Controlled Substances and Drugs Act, which allows for some of the changes that we've seen with pharmacy and prescribing around that and the relationship we have with pharmacists and what we now can do that we couldn't do before. It was also the same week that the college released recommendations on telehealth and virtual health. And internally, it was when a lot of us were shifting our practices around carries, et cetera, et cetera. So all of this came in the tail end of that March 23rd, 24th week, I believe it was. And so while we as prescribers had a lot of questions as to how best approach this. There were also a lot of questions from other stakeholders and other members of our teams, as well as other partners that we often work with. And what was happening, I think, is there was a lot of interpretation being done within the context of individuals' particular settings, which only added to the confusion. So I ran to the BCCSU and I said, I think we're going to need to sit down and take a mindful look of what is the intent of this document. Further to that, Christy and I actually touched base earlier today, and did take note of the fact that these were written at the time when we were all surge planning. And that's changed a bit. The surge that we were planning for has, knock on wood, not occurred to the degree that we had anticipated, at least not yet. And so that also shifts how we approach things. And finally, every health authority has subtle differences and nuances, and in some cases big differences, and not so nuanced. And so this was an opportunity for us to ask questions about what about this specific patient population that we have in Fraser Health. So lots of us do lots of work with people who still have jobs and have children at home and perhaps have jobs in safety sensitive positions. There are those of us who work with youth, those of us who do more of a telehealth base. So what does this all mean for us as prescribers and as physicians and nurse practitioners when these guidelines are placed in front of us?
Thanks, Dr. Vittler. I'm now going to pass it over and give Christy screen control to walk us through the rest of this presentation. Over to you, Christy.
Okay, let's see if I can get the screen control to work. Okay, it's making me open my system preferences, which I already feel is not going to go well, Amanda.
Okay. Well,
I have to quit GoToMeeting and reinstall it to share my screen.
okay. Let's see here. Lisa, can you give me access? Oh, there we go. All right, I'm happy to do it. Over to you, Christy.
Okay, perfect. I'm glad we didn't try too much there, Amanda, because I feel it was a lost cause. At any time it says to go to your system preferences and adjust something, I'm like, oh my God, no, not for me. So I'm so delighted to be here to chat about this because I think it's so interesting. And this is my third one of these, and I just love the conversation and I love the talking through the challenging cases and talking through the different contexts because you know, this is just a tool for you to apply to your practice and it's going to look different everywhere in BC. So I think it's nice to talk through that. So we want to describe the key strategies for risk mitigation during these dual public health emergencies. We want to talk about selecting pharmacological interventions based on evidence as well as based on expert consensus for meeting a patient's needs, circumstances, and preferences. We want to appreciate that this is quite complex and it's quite diverse across BC. So we want to employ strategies to facilitate continued access to medications in the context of COVID-19. So we don't want our OAT patients falling off OAT and developing a contingency plan. So the COVID pandemic, these slides are out of date. We are trying to just say pandemic prescribing now, not safer supply. So apologies for that, because well, we can talk more about what safe supply means because I think it means a lot of different things to a lot of different people. But we can all agree that the reason that we're prescribing this is because of this COVID-19 pandemic and the population that we take care of. So we want them to be able to do the same thing that we can do, which is the distancing to prevent or reduce their risk of exposure to COVID-19, and then for our colleagues, like our pharmacy colleagues, our nursing colleagues, to also set them up for safety and reduced crowding in health services. And so we aim to employ strategies to ensure safe access to substances to reduce the risk of harm and death that can be associated with destabilization or withdrawal. So let's talk about these guidelines. So they're not quite a guideline because they don't meet the bar, I don't think, for the review and like sort of rigor that goes into a guideline. So they're more just a guidance document for things that we can think about when each individual is sitting in front of us in our office or on the FaceTime to say, like, what do you need to be able to stay at home and to avoid exposure to COVID? So we thought about different categories of opioids, stimulants, illicit benzodiazepines, tobacco, and alcohol. We're going to add on cannabis as well. And then the goal is support them to isolate or maintain physical distance. And so this is not really treatment, but often, you know, all of this really reminds me of my time doing IOT, where it helps people, I think, engage in treatment, but it's still really an unknown. So who is eligible? It's very broad, and we made it broad on purpose, which can sometimes make it more challenging and sometimes makes it easier. So it's anyone who's at risk of COVID-19 infection. So basically that's anyone in BC. It can also be for confirmed COVID positive. So you might approach that a bit differently if you had someone who has a confirmed positive in terms of how you're planning out how you prescribe for them. And in the suspected case, so if you have a patient who you've swabbed and you're worried about, and you're like, okay, I'm going to take 24 hours or however long it takes in your area to get the swab back. What's my plan over today? What's my plan if it's positive for the next 2 weeks? And what's my plan for if it's negative? They have to have a history of, they have to be an active substance user, so that they have to be using substances currently. They don't have to be a daily user. Some, I know often for our stimulant users, they're binge users, so they'll use 2 or 3 times a week, sometimes just once a week. They would also be eligible, but if someone hasn't been using drugs for months, they are not eligible for this. So I know a lot of people, when this came out, were worried that it would destabilize their OAT patients. The same thing happened for me with IOT, where my patients didn't destabilize because they would come in and they would be on, 100 of methadone, doing great, all the urines in alignment over the past many months. And they'd say, Doc, I'd like to start IOT. And I'd be like, oh, you're too healthy. Like, look, you're doing great. And you'd have a nice chat with them. And in the end, they're go up 10 on their methadone and are happy with that, because this is not an opportunity to start new drugs that you're not currently using. And you want to have people who are at risk of withdrawal. Okay, so how did we develop these? So there's not a literature about this. So we could be very frank to say that this is not an evidence-based guidance document, but we can extrapolate from the literature and from the knowledge of other interventions that are parallel. So I think a lot about my experience in IOT, that having people who are unstable, those patients that you can't get up to a therapeutic dose of OAT, and they're having overdoses, they're not on their ARVs, they're doing survival sex work, all of people who are quite vulnerable, and you start them on IOT, and then you add on some methadone, and 6 months later, they taper off their IOT, and they're just on methadone, and they're stable. And so it's been a really great experience for me as a clinician, in that I think my IOT practice has really complemented my OAT practice, in that I can titrate my OAT more quickly and get to a nice therapeutic dose. And that people who were not stable on OAT, something happens when they're on IOT for a few months, and then they can be stable on OAT. So we've done a lot of times where we'll microdose them onto Suboxone, or convert them over to just SROM alone, and they do great. TIOT as well. So TIOT we developed at the PHS. Well, for IOT, for the literature, is quite robust. There's a Cochrane review, there's multiple randomized control trials, and then it shows it decreases illicit substance use, it decreases mortality, it retains people to care quite well. So we can feel good about the IOT literature. For TIOT, there's no literature, but we do have a nice case like chart review that we did as a QI project at the PHS. And so that's more of a PRN model. And I created that because the IO program is quite rigid. Like, you have to be very organized and attend the program twice a day and go through the titration. And then you have to sit and wait in the post-dose observation period. And if you have schizophrenia and you're paranoid, or if you're quite disorganized, you're homeless, you're also a crystal meth user, it's very challenging. And so that's why we created this PRN program, where there's no titration. You can just come and go as you like, and you can get 2 8-milligram dilaudits to use inside the OPS. Managed alcohol programs is near and dear to my heart because it's a Canadian intervention invented in Ottawa. We have 2 programs in the Downtown East Side that I run at the PHS, and there's quite a nice body of literature to support it. Most of the literature is qualitative, but it's quite beautiful and touching to read. Bernie Pauly, Dr. Bernie Pauly, who is a nurse scholar at UVic, is one of the lead researchers in Canada, and I always just have to give her a shout out for how wonderful she's done at doing these Canada-wide cohorts for managed alcohol, and to show that it decreases violence, it decreases interaction with police, decreases ER visits. And then as a clinician who works in managed alcohol programs, often people will reduce their alcohol over time. Because if you are a non-beverage alcohol drinker and you're drinking to avoid seizure, and you're living in the park, and you get some sherry or you get your Listerine, you drink it very quickly because you're worried someone's going to steal it, and you're just trying to avoid withdrawal. And then when you start in on a managed alcohol program and you get a set amount each day, you sort of have a moment to just have a breath, have a sleep, and have some consistency in your life. And you can let go of that anxiety. It takes weeks to months. And then we know that over time, people
Oh, Christy, I think we lost.
of addiction medicine. Oh, hello?
Oh, sorry, Christy. I think the last 30 seconds we lost you there.
Oh, sorry. Just chatting myself in my bedroom here. Okay. So managed alcohol programs that people taper over time. Like once you're stable, once you're feeling better. And then nicotine replacement is something that we're very familiar with as family doctors and addiction physicians. And that really, I think, is a bit of a tongue twister at first, where you're giving the substance that they have substance use disorder about, but you're giving it in a safer way. And you're giving it in a different formulation. Sometimes it's long acting, sometimes it's short acting. It's what the patient prefers, but has really good literature to show that it works really well. We also have some unpublished research from Vancouver that shows that illicit hydromorphone use decreased illicit fentanyl use. Oh, so I didn't realize these slides were coming. So we can skip through, Amanda. And then what about pain? So I think pain is really important to think about here, because this is something I've done a lot of thinking about as a clinician over the past 4 years since I started my IOT program. That often people with opiate use disorder will identify pain as the reason that they use opioids. But these interventions for opiate use disorder are not interventions for pain. So sometimes I've had referrals to the IOT program for a chronic pain patient who is on oral opioids and not doing well with their pain management. But I would say no, like that someone has to be an IV drug user to go on IOT, and they have to have opiate use disorder. This is a treatment for substance use disorder. But at the same time, a lot of my patients that I was starting on the program identify pain as the reason that they use drugs. So it's quite subtle. And I think that often what it is that the patient's own experience of their pain and their own experience of their life doesn't always translate into what is their risk of death. What do those urine drug tests tell us? Do they have a risk of overdose? Or have they had many overdoses? Have they been on methadone or Suboxone or Cadian? And so discussing that person's own feelings and reasons for drug use is an important thing to talk about with patients, but it's actually independent from their risk of death. So all of these interventions that we're talking about for COVID pandemic prescribing are interventions for people who have substance use disorder. They're not pain interventions, but the person might identify their pain is getting better. So it's a bit of twofold. So we have sort of some tools that you can use in your toolkit to talk with about patients and just have a really nice fulsome conversation with them to say, what is it that you're using? I always like to ask about money because I find patients will say, oh, I'm using as much as I can get. And I'll be like, oh, how much that is? And they're like, it's a lot. Let me tell you. And I'm like, oh, God, can you narrow it down? Sometimes you get caught up a little bit in that. So I like to ask, how much money do you spend? And if it's $20 or $100 or $1,000 a day, you can get an idea of what their tolerance is. And it's also, this is much easier to do when they're your own patient and you have their urine to look back over time. So for opiate agonist treatment, we always want to optimize OAT. That is our backbone of our treatment. We know that it decreases mortality and we know that it's the gold standard. So when you have someone sort of sitting in your office or looking at you through your computer screen, OAT is always the thing we want to go for first. Then we can add on some PRN short acting. So this is very similar to IOT. And I think that it's quite a nice thing to do because I can think of times in my life, like I work in the downtown east side. I should have declared that as one of my biases. I always like to qualify it whenever I do teaching that my work for the past 10 years has been in the downtown east side. And I think that how could I help it, but it colors my practice. But I'll have a parent to the downtown east side to find their kid. Like this happens quite a bit that we'll have parents come and just walk around the downtown east side trying to find their kid who's in their 20s who is homeless and using drugs. They'll come to Insight and they'll be looking for their child. And then they'll bring them into my office and sit down and be like, okay, I'm taking Tim back to Mission with me. What can you give him to help him not use drugs anymore? And, if I would be like, oh, here's 30 milligrams of methadone. And they'd be like, the patient would say, well, I know that's not enough. Like I have to keep using drugs. And it would be such a funny thing to explain to this parent. I know the opiates I'm giving your son are not enough to alleviate them from withdrawal, that we don't expect abstinence at the beginning of a methadone titration. And so that you're taking them back to Mission and taking them away from their source of drugs, like they're sort of going to start throwing up in your house because they're going to be so uncomfortable. But now we sort of have this extra tool that we can say, okay, I'm going to start you on methadone today, and I'm going to start you on some PRNs as well to make up, probably not the full difference, but to at least alleviate that terrible suffering that people have during their OAT titrations. So I've definitely found from my TIOT program where I'm giving out the tablets, my goodness, we have titrated OAT like superstars. I always have to shout out to Supreet Claire, our physician who works in that program, that we started people who had I think almost 100% of them had overdoses, and many of them were not on OAT at all, and they were declining it. And then now most are on OAT and most are on a good dose because they have had that relief in that time of titration that is so challenging for patients. For benzos, this is the one that makes me the most nervous, but it's similar to how I think if you had a patient who was using illicit benzos and wants to come to you to have a taper, that you might try to stabilize them as an outpatient, or maybe if you have the luxury of having an inpatient withdrawal management facility, to send them there to figure out what their benzo dose should be. And then I follow the Heather Ashton program. I am never in a rush, so I do a tape over 6 months to a year, depending on how long they had been using benzos in the first place. So for benzos, I think that we're sort of, it feels very uncomfortable is for me, and I think for a lot of us, to start benzos when someone's reporting illicit benzo use. But in my mind, this is the one that we're going to do a 6 months to a year long taper, depending on each individual and depending on what happens with COVID. For stimulants, here we are the most in left field, I think, in terms of looking at the research to support this prescribing. That there have been trials to show that it doesn't work for stimulant use disorder. Some of the limitations of those trials are that the doses were the ADHD doses. So there's speculation that if you're using an 8 ball of crystal meth a day, the ADHD dose is like a drop in the bucket for you, and so that it wouldn't have effect to help you decrease your crystal meth use. The trials are shorter, like 12 weeks. Like many addiction trials, one of our challenges is the length of the trial. And the other thing is that they didn't look as much at quality of life as one of the outcomes. Mostly it was use or no use. And I think that quality of life outcome in substance use disorder trials is really important. And so that's something that's still an unknown in terms of stimulant literature. And then alcohol and tobacco. So managed alcohol has nice literature for it. And then we want to offer nicotine replacement therapy. And then if they're not amenable to that, in my organization, we've been buying people cigarettes or vaping in order to help them isolate. Okay, so what we want is for people to stay with their own doctors for this. It's a person who knows them well, who's going to be providing them with longitudinal care ongoing over the many years post-COVID. And then maybe Sharon, you can maybe talk a little bit about prescribing in Fraser, not to put you on the spot. I would say, I know in Vancouver we have the RAC clinic that is going to take people who are unattached.
Yeah, so similar to that, and similar to what I think Viha has said, Vancouver Island Health Authority, that the Rapid Access Clinic is a place where individuals who are not attached to a regular prescriber can come to be assessed and see if it's appropriate, if pandemic prescribing is appropriate or if other plans can be created. And the Rapid Access Clinic in Surrey does some virtual health outreach to the emergency response centers and the isolation centers that are around the region for people that are marginally housed and homeless that have the need for isolation. So really, the defined target population for this guidance document, and care is being provided that way. That's not to say that if you are a prescriber in the community in Fraser Health and you feel comfortable prescribing and would like to proceed, it doesn't mean that you have to send that patient to us at Rapid Access Clinic. Please feel free to go ahead and prescribe, but we are available at the RAC to provide that consult.
Yeah, and you can also call the race line if you want some support. I have calls just from my friends who are like, okay, Christy, I'm starting these benzos and I'm quite nervous. And we just chat it through. And I think the key is that this is a clinical decision that you're making on the balance of risks, so that we know that prescribing benzos is risky. And it's something that stresses me out when I'm thinking about it and when I'm doing it, but that I'm documenting and I'm truly thinking that I hope that what I'm doing decreases their risk of death because I'm worried about COVID for this population. And so that it's always that balance of risk, and it's different for every patient. And that 23 days is what we have asked people to write prescriptions or any prime number, because this will help with research to identify these prescriptions on PharmaNet. Is still me, Amanda, going? Okay, so Health Canada has exemptions to Controlled Drugs and Substances Act. So it permits pharmacists to extend prescriptions, to transfer prescriptions to other pharmacies, and now we can do verbal orders with a phone for opioids, and that pharmacy employees can now deliver controlled substances. And so patients who are on OAT, we want them to be prepared and to not miss doses if they are needing to self-isolate. So I've been talking with all my patients about COVID-19. I don't know how great we're doing in the downtown east side about social distancing. I would say not great, like if you look on the news or drive around the neighborhood. But I think there's a lot of factors in place there in terms of poverty and lack of safe indoor space. And, it's just a very unique context, but we're definitely trying hard. And then it's nice to do telemedicine appointments if your patients have a phone. It's nice to extend prescription duration so that people don't have ending of their prescriptions. Consider pharmacist delivery, taking into account capacity of your pharmacy colleagues. We can stop sprinkling SROM to reduce the time spent in the pharmacy and reduce the handling of the medications by the pharmacy. And then renewal of non-OAT meds where feasible and reasonable. So you want to document well, as always, and document your thoughts and that this is in the context of COVID. And then provide support to the patients to use telemedicine. Considering my renewable prescription. So for some of my patients, if you don't want to give a huge dispense at once, you can write like, a 2-month prescription, but weekly dispense or twice weekly dispense, whatever you feel safe for the context for how they can store the medications and where they live. And then consider individual factors. So you can do carry doses if you feel it's safe. So we can have take-home dosing of SROM. And then it's nice to do this in patients who are clinically stable. For me, what matters most is the secure place to store it, that they have a lockbox and that there's no children who can access the drug. And then it's nice to have a good conversation with someone and say like, hey, like if I give you 3 days worth or a week's worth, are you going to use it all? Or do you think that you're able to like take it as prescribed so you don't just run out? And so I think people are really insightful about this and they'll be like, oh, doc, that's right. Sometimes I can get impulsive. So maybe I'll do Monday, Wednesday, Friday pickup, that kind of thing. I had to say, when this first came out, I remember the Monday at work, I was like, oh my gosh, now that I have ability to do carries, people are going to go wild for it. People are going to be thrilled. And I saw maybe 40 patients that day and only one person actually wanted take-home dosing. All the others wanted to continue going to their pharmacy daily because they really appreciated that connection with the pharmacist. We have some bulletins you can look at for a resource. Okay, so here's a case. So this is, all the cases are like composites. So they're sort of true about that they're based on real people, but the people that we put together. So it's not anyone that's an actual real case, but there's a real things that have happened and real clinical decisions that my team's been talking about. So we've been, you might have seen there's a tent city Oppenheimer Park that we've been doing outreach to, the PHS. And so we met a 19-year-old man and he'd been using IV opiates for 6 months. He had never tried OAT before. His pharmanet was empty. I put living with his parents, but he had left there to go to Oppenheimer Park, working part-time, not driving. And so chatting with this youth, he had been doing this intake for the pandemic prescribing, but really he had not had a long history of IV drug use and not had any trials on OAT. So what we ended up doing was giving him some short-acting hydromorphone daily dispensed and then microdosing buprenorphine at the same time. So this person ended up on buprenorphine. So this is another true case. I met a 45-year-old woman. She was new to our clinic and she was requesting benzos to support her to self-isolate. And we did a urine dip and it was negative. We sent to the lab for confirmation, it was negative. And then came back again and she was like, I really need benzos. And so we did a urine again, it was negative again. And then on further history, she had been on them for 15 years, but had tapered off with her previous prescriber. She had moved in from rural BC into the Oppenheimer Park. And she'd had no benzo use for the past 3 months. And so we declined to start any benzos for her. And then this was an OAT patient that I had. He had 10 years of crystal meth use. We don't have, well, I don't have anyway. I don't think as a community of practice either, we have a lot of experience because I wasn't doing any stimulant prescribing at all before this change in the guidance document. So I don't have that sort of clinical gestalt yet built in about dexedrine versus Ritalin and what patients like and what works for either. So I've just been asking patients, have you used either of these on the street? Like, do you have, what would you prefer? And so we ended up daily dispensing 10 milligrams of Ritalin for this person. I put 7 days here because at 23 days is nice if you could do it, but often it ends on a weekend and it's logistically hard. And I think it also depends on the follow-up that you have, that if you want to see the person more frequently than the 23 days, you can write the prescription shorter. But let's say you're in a context where you have an outreach team or they live in housing that's supported housing where you can see them more frequently, then you can write the longer duration prescription. So for long-term management, that's always $1 million question is what happens once COVID is over. Can't wait. But that it will be patient specific and it will be substance specific. Like I hope that these managed alcohol programs that are set up will persist after COVID is done because it's a wonderful community intervention that really helps non-beverage alcohol drinkers. If someone doesn't get better on their stimulants, then certainly we should taper them. I think that all benzos should be tapered because they increase mortality and they increase HIV seroconversion. There's a whole list of negative sequelae from benzo use. And then for opioids, like I have patients who were on like 220 of methadone, and then still always fentanyl positive in their urines, and they can't go on IOT because they're working full time. And so I'm giving them some hydromorphone, and then I'm going to see what happens with those fentanyls in their urine. I think that it's been really great to have this short acting bridge to help people on OAT titrations. And so that's why we're not sort of able to really predict the future of what will happen for prescribing post-pandemic, but just that it's shared decision making with our patients. It's based on their function and their safety, and that nothing is abrupt. And so that's the kind of thing you want to document, to say, did this person attain housing? Did they decrease their substance use? What do those urines look like over time? Were they overdosing before and they're not overdosing now? And then we're going to adjust this in accordance with the evolution of the pandemic. Although we have to remember that the opiate overdose epidemic will likely continue. And then formalized research of these approaches is needed to inform the future prescribing, and possible continuation in this, like, quote, safe supply framework. I always think safe supply is what the government should be doing, to that people should be able to purchase drugs like in a regulated fashion, like not like going to the liquor store, but like it would be more constrained than that. But I think that what prescribers do is patient specific and written on a prescription pad. And so as prescribers, we make these shared decisions with our individual patients over time.
Great, thanks, Christy. So at this point, if you have any questions or any cases you'd like to discuss with Dr. Sutherland or Dr. Bippler, please just raise your hand in the questions box, and we can unmute you so you can ask those questions. You can also type to us as well. I do see a couple hands raised. I'm gonna try this. John, did you still have a question? John Hamilton, I'm just gonna unmute you here. So if you wanted to unmute yourself, you can go ahead and ask your question. There's a question through the chat here, and maybe Sharon, you can speak to this a little bit more, but there's just a general question asking if there are safer supply prescribers in Fraser Health right now, perhaps outside of the RAC that you're aware of. Oh, you might be on mute. Sharon, are you still there? Lisa or Christy, can you hear me? Sorry, some technical problems here. One sec, folks.
Oh, good.
Oh, there I am again.
Can you hear me now?
Amanda,
Okay,
I think you unmuted everyone, and then I couldn't unmute myself.
Sorry, so sorry. Okay, I muted everyone. Sorry, I just held the mic
You're
there.
enthusiastic, Cheyenne. Just a real, running a tight ship.
Okay, sorry, over to you, Sharon, if you had any comments with that specific question.
Yeah, so I actually couldn't see the question, but from what I understand, the question is if there are identified pandemic, like individuals that have identified themselves as pandemic prescribers outside of the rapid access clinic. Is that correct?
Yeah, or if you just know generally if prescribers are offering this in Fraser Health Authority.
There's no one kind of identified. Are there prescribers, at the clinics that are moving towards, like looser approaches to carries, or adding short-acting opioids in an attempt to do inductions or in an attempt to stabilize during an up titration? I can say that there are prescribers throughout the region that have been doing this. But again, it's on a case-by-case basis. And what I am noticing is that when I am hearing about this or being called about cases more often than not, it's situations in which the prescriber has a pre-existing relationship with that patient.
Yeah, it's much easier to do when you already know the person.
Hmm.
And it's a lot of work. I can also say that, like that for doing these new intakes at Oppenheimer Park, it's like many hours of physician work that causes many hours of admin work and pharmacy work. So, just to acknowledge that physicians are taking on a lot by providing this service.
No other questions in the chat, so go ahead, folks, if you'd like to ask there. But also, we totally welcome if you want to discuss any cases that you have that you'd like to speak in person with our two presenters. Not seeing any hands raised in the queue either. Sharon, are there any frequently asked questions that you receive that you could share while we're waiting for questions to come in?
Not so much frequently asked. I heard of a kind of a neat case today that I don't mind sharing. This was a colleague of mine who had a patient that she was up titrating on Cadian, and actually the patient was starting to show early signs of stability. Use had decreased, so it was no longer daily, is my belief, and they were hovering around the 1,500 milligrams of Cadian dose at that time. And then in the last few weeks, as you can imagine, there's a lot more stressors. There was something about a concern about being at home with elderly parents, and the patient relapsed and missed 3 days of her Cadian dose. And so the plan that was created for this individual was decreasing the dose of Cadian by 60 milligrams as per the guideline, based on the number of days missed. And then providing daily dispense of immediate release hydromorphone to allow for up titration, and kind of rolling up the hydromorphone that she was using into the equation when up titrating the Cadian. So normally we would go up by 50 to 100 milligrams, but knowing that, as recently as 3 days ago, this individual had a consistent tolerance for 1,500 milligrams, potentially up titrating by 100 to 200 based on how much hydromorphone was being used. So I think what this case highlights is, pandemic prescribing isn't just one thing. What it allows is for us to take a moment and say, like, well, okay, maybe I have a few extra tools in my tool chest now that will allow for this, what normally is a much longer process, to be done in a more controlled fashion over a shorter duration, resulting in a faster stabilization period. So that was a case that I had just heard of today.
Yeah, I think that's such a good case, Sharon. And it makes me think about sort of even the changes in our treatment of opiate use disorder over time with the overdose epidemic and the fentanyl, in that, in the past, we were always starting at 30 and going up every 5 days. And now on the downtown east side, we start at 40 and we go up every 3 days. And we've changed that as a community practice. All the clinics do it the same. Just in looking at the change in the balance of risks that, 5 years ago when it was heroin, and people knew what they were getting and they weren't overdosing on it, it was much safer to do the slower methadone titration so that you didn't overshoot on methadone. But now with fentanyl and carfentanil and people having multiple overdoses sometimes in one day, it's safer to go faster. And so we can see that it's always the context and the risk that changes. And it's nice to be able to support patients to be safe.
Any other
Great.
questions? I don't see any in the chat.
Yeah, there's none popping up. Give folks just a last chance here to type them in.
You guys are very quiet. Like Island Health was like all over this like a rash. They were like, Christy, what about this? They were giving me just the most challenging cases, which I love. I'd love to hear a challenging case. But I think one of the things that we really wanted to bring across with these webinars is that this is not mandated for you to prescribe in this way. It's not required. It's for you to apply as you like in your practice with your patient population in a way that fits you. And so just the way, I was thinking about this morning, diabetes updates come out and they don't really apply to the downtown east side. And so I'll like read them and think about them and then think about the way that they apply to my patient population. And so we can invite you to do the same here for this, that it might be that you don't use it at all and that's totally fine. Or it might be that, at my clinic, we've started already 161 people on pandemic prescribing and it's going really well. It's really nice. I also reflect about outreach workers and nurses because this came up a lot of times for in IOT. Whereas physicians, we see what we see. You know what I mean? Our patients who walk in our doors, the one we see, and often it's the outreach nurses and the street support teams that see the people who aren't coming to see us, and their voice was really valuable when talking about IOT. Where sometimes as physicians, I think we're like, oh well, we'll just titrate the methadone faster, or we have all these other ideas, and they would be like, no, people do not want what you're offering. They want to inject, and so if you build it, they will come. And that's really what happened in my clinical experience with IOT. And then I created this program, and I saw so many people whose pharmanettes were empty, and who had been injecting for the past 20 years and did not want methadone. But then I sort of built this new program, and they came, and then often they start methadone anyway. Sometimes they don't. We have like 1 or 2 people on the IOT program of the sort of maybe 400 over the past 4 years who totally declined OAT the whole time. Maybe 5 I can think of, but it was quite rare that people then didn't ever start OAT.
Great. Well, seeing no additional questions, you've just answered everything perfectly.
I'm
Both of you.
baffled. Yeah, totally. I mean, this is unprecedented.
Sharon, did you have any final remarks for Fraser Health folks about resources or access?
No, so we've got our rapid access clinic in Surrey that's taking calls or doing consults on a case-by-case basis and is the go-to connection for, as I mentioned, the vulnerable patient populations that are in the emergency response centers and the isolation centers. For those of you that are Fraser Health addiction medicine docs, we have a call every Friday morning and we talk about lots of stuff, but this is definitely something that comes up. And so if you're saving your cases for Friday morning, that's okay. We can talk about them then. And of course, there's no need to wait for those times. You can always shoot myself an email or a text if you've got a case sitting in front of you that you're kind of mulling over and would like to ask a friend. So that offer is out there. But just to reiterate some of the points that Christy made, that this is still medicine, and you really can only answer the question based on the patient that's sitting in front of you. So do what you do in every other case, which is a risk-benefit analysis. And what this guidance document provides is a few more tools within that. Not a very deep toolbox that we have, I have to say, in addiction medicine. So this is adding a few more things, keeping in mind doing that risk assessment. And if it's your first or second time prescribing, please reach out to those of us who are available to help with that.
Great, thank you so much, Sharon. And so we'll stop it there. So a big thank you to Christy and Sharon for hosting this webinar with us today. We hope you have a great rest of your day, and we'll be sharing the recording and slides so you can refer to these later. Have a great evening, everyone.
Thank you.
Thanks, everyone. Bye.